It's okay. Well, I'm going to call upon our next speaker. He is an independent speaker here, and he's going to talk about something critical, obviously, in healthcare: innovation. Please put your hands together and welcome Associate Prof. Dr. Chew Heng Hai, the Deputy Director of Non-Invasive Medical Intervention from AIMST University. Put your hands together, guys. As Prof.
Very good morning to everyone. I'm happy to be here. I'm very happy, and thanks organizer for inviting me, giving me opportunity to be here today. Thank you, Dr. Selina. I'm very impressed with what Disruptive Doctor has done. In only few years, they successfully draw such a big crowd. So today's my topic is going to be, is given by Dr. Selina, this topic. So I'm going to talk about innovation. Usually when we talk about innovation, we always refer to AI, other high-tech technology. I'm trying to bring you on the other aspect. But the concept is the same. So why should we innovate? So when we talk about why should we innovate, because medical doctors should innovate because we need improvement. Innovation will improve what we are doing today. And our main role is to solve problems. And it's because we already have sufficient medical knowledge. We are better person to innovate in medical field rather than people, let's say engineering people or anything. And innovation, let us see the lifespan of innovation is just like frogs. So we start with problem, and we are given problem. Patient come with problem. AI could be a problem also. So we solve that. So, and in the process of solving the problem, we start to use guideline first. When that all fail, you're not going to stop there. You cannot chase away your patient if you have caring to the patient, you try to solve the problem, you may come to an idea, a new idea. So, and you persevere on this idea, it can be a breakthrough discovery in medical science. And then later, it's updated in medical field. And then ultimately, it go into guideline. So, during the having in the practice guideline, everybody use it. There will come a time that this guideline will be outdated, or we may discover the weaknesses of the guideline. So we need a new innovation. So we need to be ahead. We cannot just be guideline follower only. So when you say why should doctor innovate, I think we won't bother to know why. If you do not know, usually when you say, ask doctor to innovate, why should I? Because we have the doubt. Can I? And I don't know how to do it. So I'm going to answer this so that I want to show you how simple it can be. So because as a doctor, our role is to solve problem. To become a good doctor, you have to listen to the patient. You have to be caring. And when, as a specialist, it's easy. You just solve things within your specialty. But as a GP, patient come to us. I'm a GP for information. Patient come to me and they tell everything. They don't bother what specialist you are. So, how to innovate? Actually, what we do as a GP, we have already doing the most important part of innovation. We need to communicate, we need to be caring, with compassion, and we keep learning, and we may come to the solution. So how to come to solution, and the simple tool that we can follow is keep asking why. But if you have a problem, you keep asking why. There is one tool called 5 whys analysis. Most of the time, you will understand better. So to have innovation, interest in innovation that will add value to your practice and encourage you to learn more. So next thing is, can I? A lot of time when you talk about innovation, we think this is Western world. The trendsetter is Western world typically, and we are just follower. So I think that mindset we have to change. So to innovate is, first thing I think is caring. You have to be, you feel you're obligated to solve the problem. So when your guideline fail, you still want to solve the problem. That is the first step towards innovation. So I'm going to lead you through one example. If I just keep talking like that, I think you may not get what I try to say. I give you an example. Chronic anal fissure. I think we all know chronic anal fissure. When the anal bleeding, we always think it is hemorrhoid. Hemorrhoid is dilated vein. Without a tear, there won't be bleeding. So usually, anal fissure associate with associate with hemorrhoid also. And a lot of anal fissure has been just diagnosed as hemorrhoid. So anal fissure is just a tear at anal mucosa. Typical symptom, pain and bleeding during defecation. And the gold standard treatment, in GP we don't have anything to give, we give hemorrhoid treatment. And the treatment, conservative treatment with hemorrhoid is the same. Make sure the patient drinks sufficient water, easy to pass motion. And we give hemorrhoid treatment also. Gold standard is surgery, lateral sphincterotomy. So, it is there, and the reason why it goes chronic is widely accepted as because of the spasm. Because of the spasm, it is believed to reduce the blood vessel. So, believed to reduce blood vessels, that's why the fissure doesn't heal. So, and just now, I think I missed, one important sentence I think we should highlight. In the process of innovation, we have to read more. I think as a doctors, we need to read more. And one thing we have to do is, we have to be there enough to draw our own understanding based on the facts, based on the evidence. We don't just follow the conclusion of the author. That is the first step toward that. So, when we come to this anal fissure, we blame on the spasm that reduced the blood vessel. And that is the reason why they do lateral sphincterotomy, a surgery that they cut the sphincter. This is the picture of the anal fissure. This is at the 6 o'clock position. And more than 90% of the chronic anal fissure is at 6 o'clock position. 6 o'clock position. And it is believed to be due to the spasm because the blood vessel comes from either side, and the midline is the ending of the blood vessel of right system and the left system meet. So these are based on evidence. This Professor Lang, John Lang, he conducted a clinical study on cadaver, and he found out 6 o'clock position has the least number of arterial. And we know that oxygenation takes place at capillary. It's not arterial. And down there we have so much of blood supply. And if you think this is ischemic ulcer, lack of blood vessel, supposed to be ischemic ulcer, it should be gangrenous. It's not easily bleed. But typical feature of anal fissure is easily bleed. And you look at the picture, it's granulation. It's a granulation tissue. And these are the evidence of healing ability, the scar, which is we call proximal hypertrophic scar, and the distal we have sentinel pal. So, and why it is 6 o'clock position? I cannot accept the logic that lack of blood supply. That start my curiosity. So, this is the surgery, how they do. They cut the sphincter. The intention is to cut the sphincter, internal sphincter partially, so that it have unable to grip. All right? And by you cutting the sphincter, one of the most important complication is incontinence. You lose your ability to squeeze. They said they cut it so accurately, it will not have incontinence. But evidence show about 30%, up to 30%. Some papers say less, some papers say more. I asked colorectal surgeon, every one of us, when we go old, naturally our muscle will become weaker. Certain percentage of us may end up in fecal incontinence regardless of we have undergone the surgery or not. What will be the percentage of person who has undergone the surgery? Logically, it should be more. Then, that curiosity led me to further study, and I want to summarize it in the very simple way. Started with inner fissure, led me to more understanding. That is the benefit of when you have curiosity, you have interest, and you have purpose to study more, even not for exam purpose. So I think it is not due to the spasm theory, it's because our physics come from the back portion. It is guided by sacrococcygeal bone. Beyond the sacrococcygeal bone, it started to push on anococcygeal side, which is come from the posterior aspect. So that part lack of support. So I try to create the support for a patient. Then by doing that, the sagging is prevented. And see what happened to my patient. This patient has 20 years of inner bleeding. 20 years because he remember it clearly. First time he had inner bleeding when he was SRP, after SRP exam. And after 2 weeks, just by supporting, they drastically remove the bleeding and pain. So, and it further to clinical study. This is the control study where there are third party, not me. It was done in HKL by colorectal surgeon, 5 colorectal surgeons. 52 patients offer, these are 52 patients are in waiting list. They are offered to have alternative, just to delay their surgery if they want, using a conservative support method only. The first 30 patients all want the conservative approach. So the subsequent 22 is subjected to surgery because they have been agreed for surgery. So at the end of 8 weeks, all of them healed. Then remember, these 5 clinical, the researchers are colorectal surgeons. And how many of them have incontinence? In this paper, they do not mention about that. But what will happen when you go old? So, with curiosity of inner fissure, it led me to a lot of discovery in pelvic floor area. This, let me share in a very simple picture way. I love drawing, and that is all my drawing. So, this is pelvic floor of a male. And for a female, the only difference is have additional hole for vagina. And we remove the superficial pelvic floor, and this is deeper one is muscle. So what is the purpose of muscle? What is the purpose of pelvic floor? It has 2 main functions. One is to support. It supports all the organs above, including abdominal organs. And The other function is sphincteric action. So the puborectalis muscle, it acts as a common sphincter for all. So when it's squeezed all together. So when our pelvic floor weakens, the first symptom actually constipation. These studies show bowel dysfunction correlate exclusively with posterior aspect of pelvic floor support. So majority of pelvic constipation are obstructive type because of sagging of the posterior aspect. This is not my paper, other person's paper. So with that logic, and we understand that it sag, it bend the passage. That's why we benefit from fiber water. When your stool becomes soft, even though it's bending, it still can pass. So with that, when this sag, it starts to cause constipation. With constipation, we strain, and we get anal fissure. Because feces come from the posterior aspect. When it come out, definitely it will going to glide, going to push on the posterior aspect, which is 6 o'clock position. That answer why 6 o'clock position has maximum. And the solution by support, you can see how it effectively improves the posterior anal fissure. And with constipation, you have hemorrhoid. So this is due to sagging. And when the sagging is there, we keep straining. It's not only it sag, but puborectalis loosen. The gripping function started to lose. And when it starts to lose, you lose the hold, lose the grip on the urethra, which is the smallest structure. That's why urinary incontinence set in. And later on, uterus prolapse, rectal prolapse, everything through the same levator hiatus, same opening. So you can see everything are interrelated down there. They are all commonly supported by pelvic floor. To the extent, a patient can also have fecal incontinence. Start with constipation, end up with fecal incontinence. They are all because of the weakening of the puborectalis muscle. So this lead us to this understanding. When you strain for whatever reason, the pelvic floor, when you have constipation, for whatever reason, you will strain. Once you strain, the pelvic floor will be pushed down. When it is pushed down, it will contribute to obstructive type of defecation. So this vicious cycle, if you don't break it, it will cause you problem. So woman has more problem because woman gave birth to baby and have pelvic floor damage and pregnancy and also menopause, aging. So with descent of pelvic floor, it overstretch. And overstretch cause tearing cause anal fissure pain. And what surgeon do? They cut the spasm. Can that guarantee cure the spasm, anal fissure? No, because the constipation vicious cycle is still there. Same thing, when pelvic floor descend, anal mucosa exposed. During anal mucosa everted, exposed, you strain, your hemorrhoid engorge. If your every one of us has hemorrhoidal vein in the anal mucosa. So, but when we strain, when it is inside the anal canal, they are compressing each other. There is no room for engorgement. But when it everted out, and then you strain, it engorge. So with straining, you get vein engorge and hemorrhoid. With straining, it's not only descend. The pelvic floor, the puborectalis will relax, will stretch, and a day will come, every organ go through that. Start with urinary incontinence. So, then the culprit is descent of pelvic floor. So we should handle the descent of pelvic floor. So with this, started with curiosity for anal fissure, led to so many discovery, and this has been supported by at least 14 paper, guideline, and textbook. So, more we discover. Mesh complication. Women have pelvic floor weakened, they have urinary incontinence. Now the advanced surgery is using a tape, transvaginal, they hook up, hang the bladder, and that prevent incontinence, but that cause problem, lead to a lot of problem worldwide. America alone got more than 100,000 court cases. And this is the problem. And we have also discovered, from this discovery, what we do, we provide the same support for anal fissure. A patient can defecate with minimum straining, and this patient with mesh complication actually reverse. We published the first paper of, probably it's the first paper showing that the mesh complication actually reverse and recover. And this can also be used in antenatal care, because during pregnancy, when you have hemorrhoid, can you give anything? You can't give anything. And we have conducted a study, just by providing the support for women with hemorrhoid during pregnancy, it reversed and the symptoms subsided. And this is another area we have not done any clinical paper, but I believe you will support me. You see, during baby delivery, we stitch. And the stitch of the pelvic floor muscle, we know that when we pass motion, pelvic floor will descend. The descent of pelvic floor will stretch on the episiotomy wound. That's why every woman, after giving birth, the subsequent baby will be easier to come out. It is not because she already learned the skill of pushing, because down there is permanent damage. So with this, can we predict positive outcome? Because pelvic floor is not only for sex, it's for defecation also. So we prevent women after delivery from having sex 2 months. But down there, when they pass motion, the pelvic floor descend, that could have torn the wound that we have stitched. And we stitch with catgut on a muscle which is easily tear apart. So with this support, I think you can. So now you know why. So actually we can. Just keep asking, keep going to look for answer. Just like now, the AI issue is another problem. So, but keep asking, how can you solve this problem? And the curiosity will lead you to the answer. So, prevention is better than cure, and we should try conservative first before we start, explore on invasive intervention. So if you want to know about pelvic floor further, you can study this chapter. I'm the co-author for this chapter. This is ONG textbook in America. Probably I'm the only one in this textbook that non-ONG specialist. And I want to give you another few examples. In AIMST University, I'm a deputy director for NIMI, Non-Invasive Medical Intervention Center of Excellence. So probably this one is not lucrative. It's not the field that you're going to, the big boys lie about that. It's not going to generate a lot of money. But there is, I think this type of innovation, every one of us can. And some more, it's non-invasive, it is not risky, so it's easy to enter. So now I'm passionate on another aspect. Scoliosis. I manage scoliosis from this 6 months. And look at this, 7 months. And this boy, pectus excavatum since birth. And he was recommended surgery. And he came to me on 2023. He was so bad. And he refused anyone take photo on him. I did not take photo. But come to 2024, he started to be confident. He allowed me to take photo. And 2025 is this one. So conservative is under explore. So if you have any opportunity, try conservative first. Anywhere in innovation you want me to help, you can always approach me. Thank you. Any question?
Thank you so much. Yes, there will be questions. We're going to put up a QR code right now. But of course, there was a clinical presentation right there. Anybody wanting to ask any questions, please raise your hand and I will come and pass you the mic. Or you can, of course, anonymously question Prof there. We see budding innovators here. Any questions from the floor? I can come straight to you. You can directly speak to Prof. No? All right, we will just wait for a little while. Well, yeah, I can see people typing on their phones, so we're going to wait for a little bit. Nice.
Yeah, the pectus excavatum, actually I do it with physiotherapy. For your information, I'm also a lecturer in physiotherapy. So I went to physiotherapy because of the innovative, I think it's another aspect of innovation, conservative approach that we doctor, we always refer one word, physiotherapy. I'm an occupational health doctor. I am also a diploma in sport medicine. So when I was offered to lecture in AIMST University, I say I want physiotherapy. So the purpose is I wanted to know further. So with that, there I come out with my own physio exercises and breathing exercises, how I did that. Because look at the simple logic of it, just scoliosis. Scoliosis is malalignment of the bone, the spine. So normally, the spine is splinted by our muscle. And you have problem, severe problem enough, doctor will splint with metal. Is our splinting mechanism get problem? So what I did is, I use exercise to balance the muscle. It's just like orthodontic, you use a rubber band, you can shift the teeth, which is so solid. And why not the spine, which is more, the bone of the spine is porous in nature, so it's easier to move. So my secret is actually train the muscle, not generalize, segmental, to focus on the segment so that it's straightened. The pectus excavatum patient has also scoliosis. I straighten the scoliosis first, then I use breathing exercise to help him. In simple, it's that way. So, how to convince specialists to try conservative first, especially the private hospitals since they love surgery and earn money. That is the reason why I want to talk to the people down, especially in GP. So, yeah. About Cairo. That's why I say, don't believe, understand and make your own interpretation. We crack our joint. Where the sound come from? At the back, it comes from facet joint. Cracking of the facet joint has any therapeutic role in alignment? You ask yourself. So you have to understand everything. So I think I'm not here to say wrong thing about Cairo, but if you come to me personally, I'll let you know more. But read and understand, interpret yourself. I believe you can come to answer. So there's no shortcut for scoliosis. We need to build the muscle, use the muscle as a rubber band for the teeth. That's it. That is how I do. And You cannot follow exercise in YouTube, which is generalized for all. A person may have C-shape, reverse C-shape, S-shape, and a reverse S-shape, different severity. So we need to cater for individual. It's just like when you, because of impact, your car indented. You go to the mechanic, they use impact to correct it. Both are impact. So we use the impact to rectify. Our scoliosis is also due to imbalance in muscle. We use exercise to balance the imbalance. That is how it works. Thank you.
Thank you so much, Prof. That was passionate and clinical. Thank you very much. Thank you. Okay. Yeah, you know, to be very honest with you, there was a question there. I wanted to answer it. Why do doctors need to innovate? Well, firstly, because we are problem solvers, I think, primarily. So we have to solve problems in a selfless way, altruistic almost, you know, where you're not thinking of money or how it's going to benefit us. And I think that was the gist of Prof's presentation just now. A little bit of genuine, sincere necessity to help, and that you know raises the ability for you to innovate and solve problems for people who are in trouble. So that was a great presentation. Thank you so much, Prof. Now, I'm not going to waste any time. Please let me call upon Dr. Gao Yujia, all the way from Singapore. All right, he's a liver transplant surgeon from the National University Health System, Singapore, which is one of the most famous hospitals in the world. And he's going to talk to us about something kind of novel, digital twin in healthcare, what doctors need to know. Please, all yours. Stage is all yours.
Thanks. Right, morning everyone. So first of all, thank you to Selena for inviting me here today. So I'm just going to talk today about the concept of digital twins. Now, digital twin is essentially a very, very big topic, impossible for me to cover in such a short time. But I'm just going to let you know how essentially I use it in my field, which is surgery, and how that concept can be applied to other specialties as well. Right, so just waiting for them to bring up the slides. Okay, great. So I'm just going to start talking first, right? So digital twin essentially as a concept, what it means is just a virtual replica of whatever you're trying to imitate, right? So in the manufacturing world, you have digital twins of airplanes. That's how the Airbus A380 was designed. You have digital twins of entire factories where you can run simulations. So digital twin as a concept, it is not something that's very new, right? But its application in healthcare, I think, is something that is sort of untapped potential at this point in time. And the future of digital twins and how we see simulations in healthcare, moving from just purely computer simulations and guesses into patient-specific simulations. I think that's how digital twins are going to go. All right, so.
Some technical difficulty.
No
I knew it was going to happen, but on day 2, it happened.
Right.
Yeah, awesome.
Okay, great. Thank you so much. Right, so today what we're going to talk about essentially is my sort of short journey in moving from the traditional way of looking at scans as a surgeon into what I think digital twins means for me nowadays, right? So I'm a practicing liver transplant, liver pancreas surgery in NUH. My other role is that of the assistant group CTO for the National University Health System, and that's where I do a lot of my tech work in digital twin space. So some disclaimers. Right, now, the reason why I think we are looking at such an influx of new technology and innovation nowadays is because the healthcare sector as a whole is also moving into what I think is the 4th generation of development, right? Where we are moving away from pure physical systems into the integration of automation as well as physical systems into one single space. The way I started in this entire journey is with mixed reality, right, where it's the use of 3D holograms to plan for my surgeries as well as to use them during a surgery itself. Now, our journey began quite early in December 2019, and that's when we did a few of our pilots, our initial explorations into, I guess, what you can call digital twins as well, right? Essentially creating replicas of patients' organs, scans, right, from CT scans, MRI scans into 3D holograms, and looking at them as though you're looking at a three-dimensional object. So how do we use it, right? We work with this company called Epoclar from Germany. They actually have a booth outside with Cellcom DG. So any of you who are interested in trying out their applications, you can actually go outside on my right-hand side over there. So essentially what this technology allowed us to do is to convert CT scans, MRI scans into 3D holograms, right? So imagine you are Iron Man, you are Tony Stark, right? What you are seeing here essentially is that you can look at the patient's scans in a 3D space. Now, no longer on a two-dimensional screen, but in 3D. So moving holograms around with your hands, with your fingers, it is not just something you see in movies, it is a reality. Right, so this in itself is also a digital twin. Right? It's a replica of the patient's actual organs, the blood vessels, the different components of the liver. You use that to plan for a surgery. We also essentially worked together with them to develop real-time dynamic planners. So the previous image that you saw was a planning that was done on a computer. We export the images onto the device itself, and it shows you as a hologram. Right? But as you move more and more into the development of digital twins, then you can essentially move away from 2D planning and 3D visualization into 3D planning itself. So for example, in this case, being able to plan for the surgery using 3D objects, again, that is also digital twin. We then thought, well, if we can do it in planning, can we bring it into the operating theater? Right, so this is actually our first surgery that was done in September 2020, where essentially we superimposed a 3D hologram of an MRI brain onto the patient on the operating table to tell us exactly where the tumor is inside. Now again, being able to see through the patient using 3D holograms, right, brings you beyond what we would consider as traditional surgical navigation, where you have essentially a 2D screen somewhere else, right? You have all the navigation software, but it's never in front of you, and it's never in 3D. Right? So again, moving from a 2D world into the 3D world made possible by essentially digital twins. So how do we use this technology on our day-to-day practice? Right? So this is one of my transplant patients. It's actually a 9-month-old baby who was going for a liver transplant for biliary atresia. What you're seeing here essentially is that the gray color CT scan, that's of the 9-month-old baby. The yellow color object that you see is the liver from the mom that we're going to implant into the child. Now, using technology like this, we can see that the originally planned donation liver is going to be way too big for the kid, right? The left side and the bottom part is going to be sticking out. So what we did is that essentially we decided that we're going to chop off the left part and the bottom part. So this is me wearing the device during the surgery itself, removing the exact locations of where we planned to remove the portions of the liver. So you can see here, essentially the left and the bottom has been removed. And this is the final organ inside the child where it fits just nice into the kid. Our thoracic surgeons use this routinely for rib resections. So rib trauma, rib tumors. How it helps them essentially is that, again, they convert the CT scans, MRI scans into 3D holograms, superimpose it on the patient on the operating table, and that essentially will be able to tell you exactly where the tumor is inside the patient. Now, this is different from traditional surgical navigation, again, because now you have a spatial diagram and a spatial image in front of you. And what you can see is that there's a little bulge in a portion of the bone there. That's where the tumor is. We're using ultrasound scan to do the final registration and localization. But once we're happy with the image superimposition on the patient, we just lock it in place. And same thing, the surgeon wears the device as they're operating. So this is the first person view from one of my colleagues. Everything is gesture control, right? So you can actually wear your gloves and operate at the same time. We just make a very, very tiny cut directly over where the tumor is, go all the way down to the bone and where we think the tumor is. And once we have essentially isolated that space, we bring back the hologram. The use of digital twins or digital replicas in this particular case allowed us to not only shorten the surgery itself, but it's actually allowed us to remove complete steps from the entire surgery. For most of the time, when we do thoracic surgery, we have to put a camera into the chest cavity, the pleural cavity, to have a look from the inside to see where the tumor is. But now, because you can localize the tumor from the outside, there's no need for us to put the camera inside anymore. Right? That removes a lot of potential complications that may happen to the patient, and that improves the surgical outcomes, reduces the length of stay, right, and improves the overall patient experience. And this is the final tumor that comes out. Right. Point of care solutions. So I'm just going to talk quickly about this, right? Now, digital twin, again, the concept, it's about a digital replication or a virtual replica of the patient's body or the patient's functions or the patient's organs itself. Now, what you're seeing here essentially is another way of interpreting digital twins where we use the infrared camera on AR devices to identify the patient's veins in real time. So for those of you who have used things like AccuVein, Vein Finder, for patients with difficult veins, this is what it does, right? Again, it is not something that's very, very new, right, but a different way of looking at it. Using digital twins for education, being able to teach your trainees, your residents to appreciate 3D anatomy, applied three-dimensional anatomy, not on a computer screen, but using 3D holograms. Being able to proctor and supervise them in the operating theater, knowing exactly what they're looking at, because both of you are sharing the same image, right, gives you a much better understanding of whether or not your trainee actually knows what you're trying to say. Because nowadays, or usually, when we ask our trainees, say, do you know where the tumor is? And they say yes, we assume that they know where it is, right? And sometimes we find out intra-op or during the operation that they don't actually know what they're talking about, right? But using this, you know exactly what they're looking at. You can essentially guide them through the entire surgery itself, just using essentially a virtual replica of the patient's organs. Patient counseling, being able to create patient-specific 3D holograms or 3D replicas of their own organs gives them a much better understanding of how the disease process is, why certain surgeries for some patients are a lot more complex than others, although they sound the same or they are called the same procedure on the paper itself. But of course, there are limitations to what this technology can do. One thing you'll realize is that the way we look at digital twins now, or essentially virtual replicas of organs in this case, one of the biggest issues is that they are static. They are not moving. They are generated from images or scans done before the surgery, and essentially once you generate the diagram, the image itself, it doesn't move anymore. You can move the whole thing, right? But you cannot manipulate or change its shape. So where do we go from there, right? One of the biggest problems that we face is that in order to move and progress with digital twins, you need to solve the technology gap. And one of the biggest problems with technology gap is how do you transmit real-time information to allow the AI to work in the cloud, in the processors, in the servers, wherever it is, right? So we went about essentially installing our own private 5G network in a hospital. This allows us to have real-time communications. So we renovated our operating theaters to have our indoor 5G antennas that allows us to deploy the private network. And what it allows us to do essentially is to then create the entire ecosystem for which a digital twin can practically happen. You can have the AI algorithms, the large language models for the digital twins installed in the cloud, but you need your front-end devices to send information to this AI system. And that can be solved or, in a way, improved with better communication, with customized network, where you build your network from end to end to make sure that, number one, it's secure. Number two, you can embed your AI within the network itself. And essentially what that allowed us to do is to really scale the use of digital twins within the hospital itself. So pediatric transplant surgery, liver transplant surgery, thoracic surgery, cardiac surgery, we have done about 160 surgeries using this technology in the last 3 years. And that has changed, as you can see, patient outcomes significantly, especially for the more complex ones. We've even tried to use this for remote surgery. Now, one of the things that we did is not to control a robot across distance, but to supervise and to mentor surgeons in another country. So what we did is that we actually have a program with a charity hospital in Ghana, which is about, 7,000 miles from Singapore. And in the video, what you can see, it's a live feed from the surgeon who's operating in Ghana. I appear as a small little window sitting in my office in Singapore, and I'm actually supervising and instructing the surgeon in Ghana what to do. Right, so essentially what they do is that they can convert the scans of their patients into 3D holograms. I can look at it before the surgery, I can look at it during the surgery, right? And of course, I can give them live instructions as they're operating. And of course, being able to supervise them long distance is not just the surgery itself, right? The post-operative care is as important as the surgery itself. Right, so allowing us to be able to look at the patient the day after the surgery, to supervise them for the ward rounds, to look at the wounds, again, an extended application of what digital twins can bring to the healthcare system. So what does the future hold in terms of the way we interpret and the way we look at digital twins? Spatial AI, I think, is going to be the next big thing when it comes to advancements in how we look at the way digital twins are applied in healthcare, at least in my field in surgery. Spatial AI means looking at AI, looking at data, not across a two-dimensional plane, but across a three-dimensional and even four-dimensional plane, looking at time, distance, space into the equation itself. And a lot of that comes down again to real-time compute, right? Being able to essentially gather information real-time during the process, during the surgery, during a procedure, interpret that data in the context of that particular patient and not on a random computer simulation, and giving you an output that's specific to that patient for you to use, right? So one of the projects that we started out to try and address some of this is what we call Project Thea, where this is essentially real-time 3D reconstruction at the patient's bedside, right? So what we do essentially is that we link or we use any ultrasound probe, be it the portable ones or the big ones that the radiologists use, and we track the position of the ultrasound probes and how it acquires the images. Now imagine like what you see in the movie, in Minority Report, in any of those, where the patient lies down, this scanner goes, and then after you get an image that comes out, right? So this is essentially what happens with this project. I'm not going to skip through some of the more detailed stuff, but what it does is that the AI algorithm is able to figure out where you acquired the scan from, right? The exact location. Is able to stitch those images together in sequence, so it converts your two-dimensional ultrasound images into a three-dimensional volumetric data. Right, so what you see in the top right-hand corner of the screen is one of my colleagues lying down and we're doing a scan of his neck. Right, so using that integrated network and the concept of a digital twin, what we managed to do is to convert that sweep of the ultrasound into the image that you see in the middle and the bottom right, where the green is the trachea, the windpipe, and the blue is the thyroid gland itself. Right, so being able to do this at the patient's bedside instead of sending them to the radiology unit, going to save you a lot of time, a lot of patient's time, and a lot of resources that otherwise you would need to put into this for, as something as simple as screening ultrasounds for the thyroid. But again, that is still a static image, even though it's a real-time generated one. One step better from what we had before, which is CT scans, MRI scans done sometimes months before seeing the patient, into one that's bedside. But again, one that is still static. We need to move away from static images into dynamic images, images that can deform, images that can move, but not any random movements that's based on the patient's own specific data. So Project URSA is our latest project when it comes to digital twins. What it does is that we are trying to create an exact biophysical replica of the patient's organs using their own physical properties. So what we do is that we do a 3D MR elastography scan of the patient's liver. We started with liver because I'm a liver transplant surgeon, so it's easier for me to do projects like this, right? And what that scan does is that it gives me a 3D elastography map of the entire liver. I can calculate the Young's modulus, the shear complex, the tension forces within the liver itself, and then converting that 3D elastography map and inputting it into the architectural map itself. So essentially combining two different modalities of data into one single computer simulation model. So what it does is that it allows us to use AI to interpret that scan and to give us the output and information that we need. So the first step is to figure out what are the different segments and different components of the liver, because these are important functional areas for us to decide how to operate on the patient. The next step is essentially a technique that's not new, right, but is new to medicine, called finite elements modeling. What this technique does is that it divides the liver, in this case, from one single organ into 500,000 individual three-dimensional data points. Each of these data points, because we have an elastography map of the liver, it's given its own biophysical properties. Right, so you can see that each of the elements are different in size. The differences in size is because of the differences in properties based on where it is inside the liver itself. Now, because this image of the liver is generated using the patient's own data, it is patient-specific. It is not an education model per se. It is not a random computer generation. It is a patient-specific digital twin. So how does that help then? It helps us to essentially predict what are some of the tension forces inside the liver itself, right? So this is a video where we're essentially using a tensometer to test the replica of a gelatin model that we built, right, to see what are the exact forces inside the liver, how it can compress, how it can shift, how it can twist and everything. And it allows us to build something like this, right? This is essentially the first prototype that we built. Now, you realize that something looks really wrong, because the liver doesn't behave like this, right? No organ in the body behaves like this. But this is where then you train the AI. Because the AI is seeing this for the first time. He has no idea how a liver is supposed to behave. Right? You can give it the data, you can give it the input, but the output is still something that us as physicians need to see whether or not this actually makes sense. So we refined the model over the last few months, and essentially we get something like this now. Right, where you have an external force pressing down on the liver, and what the digital twin does is that it predicts how the internal structures of the liver is going to move based on the external forces. Right, so now we have something that looks more like how a normal liver is going to behave when you press on it. Right, anyone who has poked a liver or poked an organ will know that this actually probably looks more like it than the first one. But again, it's a work in progress. But ultimately, what it does is that it gives you the ability, to do something like this, right? Where you have an exact replica of the patient's organ. You are able to plan in real time, in 3D space, how you're going to do the surgery for the patient, right? How the margins are going to look like, how the tumor is going to look like, what are the structures going to go across. And of course, having that real-time image navigation during the surgery itself. Imagine having a screen in front of you, either a laparoscopic screen or a robotic screen, that shows the actual liver with a digital twin superimposed on it, telling you exactly where the critical structures are, where the blood vessels, where a very tiny tumor is inside the liver. No matter how you move it, no matter how you manipulate it, the AI is going to track and tell you where it is, taking surgical image navigation to the next level. Right, so this is where I think, in terms of the field that I work in, the concept of digital twin has evolved from just converting simple CT scans, MRI scan images into a 3D diagram, into a fully dynamic organ that's patient-specific and useful in the output. Not just something nice to look at, but actually useful. So imagine being able to see this one day. right, where you have the actual liver with the virtual replica superimposed and overlaid on it, and as you move it, the virtual replica will move together with the actual organ, right, telling you exactly where everything is. Something that's not available today, but I think in maybe 3 to 4 years' time, given the advancements, we might be seeing something like this being a possibility. Multiple challenges, of course, right? The technology itself being one of the problems, but of course the systems, processes, workflows, these are things that we all need to overcome if, let's say, we're going to see digital twins becoming more and more common in our day-to-day practice. Realizing that the Gartner's curve is real, right? The initial hype of technology and the sudden realization that actually it doesn't deliver everything that we need or everything that we wanted to do, but then taking a step back and asking us what is the actual problem that we're trying to solve, and not just going with the next technology craze or the technology promise that comes along the way. Lessons that we learned, right? Some very painful ones as well in developing a digital twin, some very expensive one. In the story of innovation, there are always going to be people who say it's not going to work, you're going to fail, this is not going to be useful. But again, having that initial premise and an initial objective of why you're doing it in the first place. For me, is for better patient safety, better patient outcomes with real-time surgical image navigation. That's my journey into the digital twins. And of course, balancing the act between pushing the limits, pushing the boundaries, versus knowing what is practical. Fail once, fail twice, that's the price of innovation, right? And being one of the front runners. But if you fail all the time, perhaps it's a message to say that maybe you should try something else. Yeah, this is not the right thing to do. And of course, again, like many of our speakers before have mentioned, that when it comes to AI, when it comes to innovation, when it comes to new concepts, there's multiple layers that need to happen in order for us to go from an idea or a problem all the way into implementation. Right? But again, at the end of the day, it is still the bottom left that's most important. What is the actual problem they're trying to solve? Without a good problem, an idea is just a fantasy, it's just something that's nice to have, right? But you may not be able to translate from a simple trial or a pilot into implementation and scalability. Right, so this is my last slide. This is the wonderful team that I get to work with who works on digital twins. These are young clinicians, my residents, data scientists, software developers, game developers who actually built the interfaces for all those, without whom this would not be possible. And I'll leave you guys with this quote: when it comes to innovation and building for the future, do not fear failure, but be afraid of not having the opportunity to succeed. And thank you, and happy for any questions.
But we're going to put up a QR code on top there, so questions will pop up. But anybody? Yeah, excellent. Don't worry, I'll come to everyone. I'll try my best.
Okay, a very great talk, fascinating, interesting. Thank you, sir. I'm Muzaffar, Chief Medical Officer, one of the private hospitals here in KL. If time permits, I can have 2 questions. Okay. In the future, do you see yourself as a liver surgeon or as an operator of digital twins that does surgery planning for you? That's first. A second question I want to know. As a clinician, do you when the digital twins, predict, okay, don't operate on this patient, and as a surgeon, do you have an instinct say yes? So who's the patient trust? The digital twins or the surgeon itself? Thank you.
Thank you. Very, very good questions, actually. So the way I see it is that I often call technology like this not artificial intelligence, but augmented intelligence. They're not there to dictate or tell us exactly what to do, but they're there to help us make better decisions. Now, whether or not I will remain as a surgeon or become an operator, that is a question essentially for us to answer. Are we going to just essentially listen to these systems, listen to these AIs, and just take it as wholesale? Or are we going to interpret it in the context of the patient, which is part of your second question as well? The way I see it is that it is not that much different from the way we use CDSS, clinical decision support systems nowadays, right? We have automated systems that gives us prompts and warnings when patients get admitted. We have essentially prognostic scoring systems for decades, right? The accuracy not as good as AI systems nowadays, but the concept and the implementation and the way we use it, it's not that different. Digital twins are there not to replace us as clinicians, as doctors, as therapists, as surgeons. It is there for us to help make the decisions better and to improve patient safety and patient outcome. Because digital twins can give you information, but there has to be someone to effect on that information. There has to be someone to look through that to decide whether or not in this context, for this particular patient, does this apply? Is it going to be useful? Have we taken the social, economics, and other factors of this patient into account in deciding whether or not we're going to take the advice from this AI, or we're going to say, actually, in a perfect world, this advice makes sense, but for this patient, it doesn't. Right? Until the day that AI can essentially have very effective semantic and heuristic AI, where it understands the context of the information that it's looking at, where it understands the applicability of the information that it's looking at, where it understands the actual patient, I think that's where we may see some of this being transferred to the AI part, and we have more and more reliance on the AI itself. But I think until that day, a lot of the interpretation and the communication still relies on us as practicing medical professionals to use that information to make better choices for our patient. So I hope that answers the question, at least in part. Yes. Do I have time for another question? The moderator? The moderator has left. No. All right, so let me just see one more key share. Oh, it's moving a bit fast. Okay, so I'm just going to quickly answer the regulatory part of it, right? So regulation is always very important, which is why in my hospital and in our program, this is still considered an R&D program. Right, so we do have ethics board and RRB approval to use this as part of a trial and research study. In any country, in order for you to use this as a standard of care, you have to go through the proper medical regulations. Right? In Singapore, we have the HSA, US has FDA, in Europe, there's the CE mark and everything. So it is no different from any other medical device that you use nowadays. As long as you consider it a medical device or you label it a medical device, you need to go through the proper regulations and approvals before you can move from the research, the pilot and trials into actual implementation and into what we consider standard of care for the patients. Right, so I think I'm really out of time now. So I'll be sort of hanging around for a little bit, so happy to answer a few additional questions before I go back to the airport. Thank you.
Thank you. Thank you so much, Yujia. That was fascinating. Thank you. Thank you. Of course, please, make the most of the opportunity and approach Dr. Yujia. He's come all the way from Singapore, so before he leaves, if you make sure that you do some networking. That's what it's all about anyway.